So one of the topics that is very interesting in CLL is this T cell dysfunction. That's actually a hallmark of the disease, and what you see is if patients' symptoms get worse, if the leukocytes go up, you get actually an increasement of this T cell dysfunction, which is not very well defined. So what you see is phenotypically you see a more skewing towards effector memory cells, while for T cell therapy you actually want to preserve more your stem cell memory T cells. What you see is that they are less proliferative capacity, which is also an important thing if you think of CAR T cells or therapies. They seem to be kind of pseudo-exhausted, but kind of also difficult definitions that are really CLL-mediated problems with the cells. And so people, including our group, are focused on what's actually going on here and what are CLL cells doing that make the cells going to this dysfunctional direction. What we heard at the Young Investigators meeting, and also what we will discuss on Sunday, is that metabolism might be an important factor. So because of presence of CLL cells, you get differences in the metabolism of the T cells, which negatively impact function, and that could be one of tools maybe to overcome T cell dysfunction by tweaking with the metabolism. Another clear sign is that there is something going wrong with the T cell receptor activation. It's kind of slower, it's less active than the normal T cells. So maybe there lies a thing for improvement. And since this T cell receptor mediated activation might be a problem, maybe that's why some of those bispecific antibodies like epcoritamab actually improves or look very good, because you make kind of an artificial T cell receptor complex. So maybe that's what we see.